Waveforms are complicated. You have monopolar versus bipolar waveforms, microsecond versus nanosecond, monophasic versus biphasic. So what do you actually need to know? Well, first you need to understand the electroporation zones. It is comprised of a reversible zone where the cell survives and an irreversible zone where the cell dies, and tissue scaffolding remains intact. Additionally, with pulse field ablation, there is still a thermal zone if the pulse parameters are not well controlled. The original concept for cardiac electroporation actually came in the 1980s, also known as direct current ablation, by delivering a large charge of energy to a small diagnostic catheter in a monophasic fashion. 20 plus years later, whatever is old is new again, and we now break that total energy delivery into a train of smaller pulses and deliver multiple pulse trains in a biphasic manner to achieve the desired therapeutic result. In general, monophasic pulses are actually very efficient at killing cells. Unfortunately, they also cause a lot of musculoskeletal contraction, bubble formation, and thermal effects. Biphasic pulses, on the other hand, maintain a neutral charge balance, reducing neuromuscular stimulation and pain, reducing the formation of microbubbles, and reduction of thermal effects at the electrodes. As a result, today all intracardiac PFA systems are biphasic, but their pulse parameters are all different, and the secret sauce is really in the details. Pulse parameters are optimized based on a number of things like magnitude of voltage or current, the number of pulses, the number of pulse trains, the pulse duration, the pulse width, the cycle length, and more. These parameters determine whether lesions are permanent, non-thermal, and if they induce muscle stimulation or microbubble formation. And even small changes can have a major impact. So what ultimately matters? All parameters in a waveform are important. Voltage or current, the number of pulses within a train, and the number of trains delivered, how the energy is delivered, and what the electrical field looks like around the catheter. Ultimately, all of these parameters are specific for the catheter design. However, pulse width is probably one of the most important parameters. Most systems today deliver microsecond PFA, and more specifically within the range of 1 to 10 microseconds. Even this is a large range, since even a 0.1 to 1 microsecond change can have major implications on pulse efficacy and mitigation of musculoskeletal stimulation. Some systems are also utilizing so-called nanosecond PFA. However, many of these systems often deliver in the range of several hundred nanoseconds, which at the end of the day is really just 0.1 to 0.5 microseconds, and therefore is really not an order of magnitude different than microsecond delivery. Nanosecond delivery does have the possibility of reducing the incidence of musculoskeletal stimulation. However, in order to keep the same amount of energy delivery, or to keep the area under the curve constant, it also requires a significant increase in voltage delivered, 10,000 volts or beyond, in order to keep the total energy delivery constant. Such high voltage deliveries can present problems for the catheter and the generator, especially when it comes to insulation.